بسم الله الرحمن الرحيم الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين آمين.
Amen. Amen. So, Imam, would you translate that for those who don't aren't familiar with the opening prayer, please?
With God's name, the merciful benefactor, the merciful redeemer. Praise be to Allah. Praise be to God, Lord of all the world, Lord of all systems of knowledge. Master of the day of the judgment, thee alone do we worship, your aid do we seek. Show us the straight way, whose portion is not wrath and who go not astray. Amen.
Thank you so much.
I do it in Arabic so much and haven't done it in English. I have to really calibrate in my mind.
I understood. I didn't ask you to do that earlier. I just asked you to do the opening. So thank you. That might have caught you a little off guard. So we're starting a little bit late, not too late, 10 minutes behind, but I'm going to be try to be expeditious with this opening. We normally start with a clearing to really clear out our thinking and to really give everybody an understanding. And that's the audience as well as, because I think everybody that's participating understands what this session is about, what they can expect. And this is a profound conversation. In and of itself, or will be. And the profound conversation is a listening and dialogue space, which brings foremost thought leaders into a conversation to grapple with the vexing challenges of today's world. Profound conversation uses intercultural dialogue, extensive community and organizational engagement to initiate valuable cultural, educational, economic, and policy outcomes. Today, we have a number of scholars and community partners, and I'll quickly share with you their names. Their bios can be found in the Hoover app. And we have at the Navigator position, and my name is Kareem Ali. I'm actually with the Office of our Chief Executive for MLPN to my left, but usually on my right. In the Office of Economic Development, Samuel Shareef. We have moderating our conversation today, our navigator is Latifa Muhammad Turner. A part of our scholar cohort, we have two Imams, Imam Wahyuddeen Shareef, representing Masjid Wahyuddeen in Irvington, New Jersey. We have Imam Earl El-Amin, representing Muslim Community Cultural Center in Baltimore. We have Dr. Hameed El-Amin, a scholar, a cohort with M.P.A.S. We have Dr. Omar Abdul-Malik, representing Howard University Hospital. As part of our community partners cohort, we're thrilled to have Dr. Panagis Galiatsatos, representing Johns Hopkins Bayview Medical Center, and also a Dr. William Hale, representing Johns Hopkins Bayview Medical Center. A guest community partner today is Emeritus Professor William Lawson, Dr. William Lawson, representing Howard University Hospital. If I got any of the organizations incorrect or pronunciations, please forgive me. Today's topic, unmasking intersectionality, how ethics, trust, and culture influence societal mental health. And I'll start with a quote from Dr. Sandro Galea, which was really the essence of the abstract that was written to prepare for this convening today. To overcome the challenge of special interests that work against the conditions that create health, we need to extend the sphere of what we talk about when we talk about health, so that our conversation includes factors like money, power, love, hate, culture, the environment, and politics. Welcome to the arena. I'll give it over to our navigator, Latifa Turner.
Assalamu alaikum. Thank you. My name is Latifa Muhammad Turner, and I'd like to start off this conversation by listening to Dr. G and Dr. Hale to kind of reflect on what our title is and tell us what this means to you.
I'll kick off first, and then I'll pivot over to Dr. Hale as well. From my standpoint, reflecting on being invited to be here today and to have these conversations, it's a recognition that, from my standpoint, science is, a great field, but it's just a string of objective facts that don't really have a cultural identity, right? They're at many academic institutions and so forth, but it's, doesn't speak to any kind of ethnicity or culture or religion or faith. And science has a lot of promise to it. One of it is keeping us healthy, keeping us alive and so forth, or case in point, ending a pandemic. However, taking that science out into a community, isn't always best done by a physician or a scientist, right? It really needs a cultural translation in order to make it seem appropriate for people to understand and how to use it and move forward with their own health. And so being here today, I think emphasizes that medical messaging is not achieved easily by just putting out the science. We have to make people or give people the opportunity to take it and understand it and how it applies to their daily life. I think of the pandemic, and I'll finish with this comment and turn it over to my colleague, but I think of the pandemic, where we're at now, I could easily talk to someone for hours, 6 hours, 8 hours about COVID. No one wants to hear that lecture, or unless you're getting CME credit for it. So what I'm alluding to is, just like any musician, you don't play 1,000 notes all at once. You create a cacophony. You grab 2 or 3, you know your audience, and you string them together, and suddenly you got a beat. Same thing with medical messaging. Know who your audience is, know how to go out and appropriate message what you need to, so people can understand what they need from the science in order to promote health and prevent disease in their own communities. So that's what I love about being here today. And it's what I've been doing with my mentor and friend, Dr. Hale, for a little over a decade. Dr. Hale?
Sure, thank you. And I, like Dr. G, really appreciate the invitation to be with you today. It's quite an honor. And I'd just like to build on what Dr. G has said, which is the importance really of the relationship. When the pandemic came along, it didn't matter sort of how well known your medical institution is that's trying to relay that information. If you haven't already established a relationship and the trust, which takes time, it takes familiarity. And like Dr. G says, we've been working on this 10 years. So, I feel like we had some credibility when the pandemic hit because we have been out in the community. And we've invited the community into our institution, into our home, so that there was already a real trust, and particularly Dr. G, who has been very visible in the community. So many people have said they turn to him, they trust him now because they know him. It doesn't have to do where he got his MD or that he's with Johns Hopkins. He's been there.
Dr. Hale, what would you say was the beginning of building that trust? I'm sure it didn't come day one. How did you start to build that?
So I started this type work about 30 years ago when I was in Florida and began working with a couple of physicians up here at Johns Hopkins. And we did it by listening first, by going out into the community, listening, doing it with a certain degree of, a great degree of humility. And that humility came home to me one of my first times when I was so proud of myself when I was speaking at a new hospital. They brought in some faith leaders from the community. I hate to admit it, but this is what really happened. And I was so proud of myself because I always talked about pastors and priests and rabbis. And a gentleman sauntered up to me and very politely afterwards said, "I think you should expand your vocabulary. I'm the Imam." And he and his son, so I learned that there was a very active, vibrant Muslim community in a suburb of Orlando. And so I think the idea of being familiar, being out there, inviting people in. We always invited people in for a meal and for prayers. And, you know, really, partly, I think because I'm a psychologist, I'm always interested in people. And so I really want to understand people. And listening is the best way to do it.
Dr. G?
Yeah, no, and from my standpoint, it really, you know, I'm going to parallel a lot of this as being a physician. You know, you go through medical school, 4 years of learning this language, really, and diving into it and so forth. But it's not until you're bedside by the patient where you completely understand how to take that science and begin to adapt it and begin to utilize it to help that patient. And the reason why I say that is because community engagement, to me, it follows the same analogy. You can learn all you want about a community, reading about them, et cetera, but it's not until you step foot in that community, you know, to understand, you know, their culture, their faith, their identity, what speaks to them, what moves them, who the leaders are, and how the leadership and how that community really emphasizes their identity. And why that's important to me is because, you know, as a human being, I saw that with my own community, being raised in an immigrant section of Baltimore. I mean, I didn't even speak English until I was 5 because we were just such a homogenous population, really looking out for one another. And then I got to see that reflected in countless other communities throughout the city of Baltimore. And what I realized there is that unity together is so powerful. And the really only way to kind of be a part of it is presence, is coming over and over again. I had a great interview with Reverend King from Homes over in the West Side, you know, who made a point to say we trust people who are present, they show up. And that to me was the big insight to begin this relationship building, as Dr. Hale mentioned. That's key first, presence and being seen as one of the community members. That happens over time. And once you've established that level of trust bidirectionally, then we can discuss, you know, what can we do in order to promote health, allocate some resources and so forth. But for me, it really was going bedside by the community, consistently, repeatedly, you know, things that I went in more as a scholar, but, you know, I left realizing we're all human, you know, so, you know, these simple principles that I think many of us take for granted, sometimes you have to remove that academic appeal or that academic showing and just be yourself, be Panagis when you go in there. And so that to me, you know, picking up from where Dan Hale mentioned, I think, you know, whenever we discuss with a health system, you want to do community engagement, you can't launch in there with a focus on a disease, right? You're going to come across very insensitive. You enter there for relationship building first, and then you begin to have the discussion of what health means to them, let them dictate the pace and the identity of what they will like achieved. And then suddenly you can make your strategies and so forth to help them out. In all fairness, it's what we do with patients, right? I don't tackle those numbers. I hear what my patient wants out of life, and I see what I can do to help them.
Now, I heard Dan Hale talk about his kind of aha moment, but I'm hearing some of the summary of narrative, but I didn't hear your aha moment. So when did you break ground? My
aha moment came, so if you know this character, great, this gentleman, this, you know, who's now retired, living in Harrisburg, of all places retired, it was Reverend Dred Scott. You know, Dr. Hale made that introduction to me to go meet him. And, you know, I had like 3 visits to his congregation before he actually sat down and really spoke with me. And a lot of it just had to do with this conversation of just who they are as a community and you know, their frustrations with academic medicine and, you know, coming in so often. And that just, it made me realize, you can't go into the community with this you know, knight in shining armor. That was my aha moment. That's when I realized the community wants what every other community wants, is relationship building, conversations. Reverend Dred Scott was that person to me. And, you know, now almost a decade later, that person still texts me and emails me, you know, I love it. We have that. And that aha moment, I will say, wasn't just one and done. It happened consistently throughout my time. Every new community that I went into, you know, it's been amazing. I mean, with Imam Hassan, out of one of the masjids in Northwest Baltimore, on a Friday night, him and I went and prayed. You know, as we were discussing how to help out with the Syrian refugees. You know, it just, you know, everyone's culture and faith is different, but it still grounds you to being a human being and being able to engage in those kind of activities. That's my aha moment, right? Where I'm realizing health, what that means to people, it's at the simplicity, it's being a human. And you just have to understand what that makes them tick. And so from my standpoint, I've had many aha moments. Reverend Dred Scott and Imam Hassan were the two for me that made me realize, you know, all the science in the world, you got to know how to culturally translate it for the people that need it.
Can I jump in with one more thing, which I have found, particularly as we talk about mental health? I think not only is there the familiarity, bring the science, the knowledge, and you've got this familiarity, but I think I feel like I have been better accepted when I've acknowledged my own vulnerability and my own challenges. That I'm not speaking just as a psychologist, but I'm speaking as someone who has personally struggled with depression. And what I hear the feedback is that sort of made me more approachable and more willing to listen, because I'm not just coming from the peer-reviewed studies and the textbooks. I really know what it's like to go through some of these challenges.
I appreciate you sharing that. And it can relate to a lot of other people here at a mental health conference of all spaces, right? But I do want to use that as a jumping off. I was really struck that both of you had your aha moments in connection with an imam and a reverend. And so you have this kind of intersectionality of faith and health just in your narrative. And I thought that'd be a good jumping off for us to jump into our cohort of imams and other scholars and get your feedback on what you've just heard from Dr. G and Dr. Hale.
Can I begin, or would you?
Sure, Imam El-Amin.
Well, as I was listening, what was profound to me was that science is a great field, Dr. G said, but it doesn't have a culture or a religion. So what that means for what I see is in my relationship with both of them, Dr. Hale and Dr. G, is that there has to be a sensitivity and an understanding of the congregation that you're working with, be it Muslim, Christian, or Jew. And so that comes through what Dr. Hale said, listening with humility. So for me, listening and humility, they're universal attributes when people engage with one another. And it doesn't have to be, it doesn't have to be in the context of mental health. It doesn't have to be in the context of health, but these are universal concepts which bring human beings together to promote and improve the human condition.
I hear that. I hear that the science is neutral in its own sense, but is the science really neutral? I mean, I think some of the apprehensions that cultural communities have had is that, you know, they've trusted and historically they've been duped, and systemic racism is in many, and if not all of the institutions that they use, everything from housing to policing to medical care. So they may trust the individual as a gatekeeper, but they still know that they're opening up to a much larger world of issue. How do you deal with that?
I think it goes back to the question that is underscoring the topic for the day, and that is trust. And how do people build trust? And I think for us as Muslims, we know that the word for trust and the word for faith is the same word in Al-Islam. It's called Iman. And when we look at that, we understand that when we look at Iman, it has to do with how the confidence that you have in what you know is supported by what you may believe, right? In other words, our knowledge only goes with so far, right? And then after the knowledge, then you have to put faith or trust in something that you have limited knowledge of. How do you begin to develop, how do we begin to develop that faith and trust is by beginning to educate people with more and more knowledge about that which they may not understand. You know, there's a author of a book, his name is Edward N. Marshall, and he wrote in terms of transforming the way we work, he said, trust is a destiny-directed condition. Trust is a destiny-directed condition, which suggests that when we start dealing with trying to help people, we have to convince them that the direction that they want to go is the same direction that we're trying to get them to go. In other words, they have to see us working in cooperation with them to get to where we understand they are going to benefit. But at the same time, we have to begin, as Dr. Hale said, we have to begin to listen so that we can also understand some of those factors that need to be incorporated into our journey together.
I'd like to ask Dr. Omar Abdul-Malik what his thoughts are as well in terms of the faith-based as well as the medical community and this idea of trust.
You're on mute, doctor.
All right, can you hear me?
Yeah.
Okay, assalamu alaikum, peace be to you all. Bismillah. So I've been a health educator and a clinician as a PA for a little over 20 years, and I've worked with a very large array of patients, or clients as we like to call them, or participants. So one of the things that I found useful in terms of establishing trust is to avoid certain trigger phrases like saying, I understand. I learned that the hard way from my medical training when I was on the psych ward of Howard University Hospital. And one of the patients was relaying, I was a student at the time. So the patient was relaying to us students and residents about the traumas of her existence or her upbringing, a lot of abuse and drug use that was in which this patient was engaging to try to assuage her trauma. And one of the residents said, I understand how you feel. And she yelled back at him, you don't understand what I feel, how I feel. How could you possibly understand? And the guy had not experienced what she had experienced. So from that, I learned that, and the Dr. Sipek, so the attending physician, and the patient left the room, said, well, I guess you'll never say that again. But, it wasn't directed at me. The patient didn't direct that comment to me, but I learned from her comment to that intern to never say to a patient, I understand how you feel, because that's one of the first breaches in trust. We're all individuals. We don't know what each of us has experienced. And I found that people are very possessive about their personal experience and the resulting trauma thereof. So try to be a good listener. I think as Dr. Hale was saying, one of the things in which I engage is a lot of inflection. So if somebody says to me, I'm really depressed, like Dr. G was talking about his own depression. So I wouldn't say, I know how you feel, because I'm sad sometimes too. There's a marked difference between clinical depression and just feeling down. So I'll say, well, tell me about that. And then allow the person that kind of opportunity to express how they're feeling in their particular terms. Everybody has a different level of articulates or a different way of articulates. Some people use a lot of what we would consider profanity. Some people act out. So I've had people in my office start slamming on the table, and in some cases even throwing stuff, from my desk. And I try to get them to calm down. Others start sobbing uncontrollably, but allowing them that freedom of expression. And then that I find, once you do that, once the person is able to be spoken to, they'll say, wow, I really feel better now that I've been able to talk to you. and use inflection. So I'll have a patient say something to me like, we're talking about depression. So I feel really depressed. This happened to me in my childhood. This is happening to me now. And then I'll say something like, well, if I understand you correctly, what you're saying is such and such. And it's like, yeah, that's right. See, that's what I'm saying. You're the only one that listens to me. And I've had people say that to me very often. So, you know, number one, establishing a kind of safe space for freedom of expression when it comes to dealing with your clients or the people to whom you may be trying to offer mental health services. And then once you allow them that freedom of expression, no matter how you may feel about it, try to look at steps with as far as maybe contacting each of their the points in their lives. I had, for instance, I had a brother, it's a Muslim brother. He was dealing with drug abuse from a very violent childhood, and he was still living with his mother. He was in his 30s. His brother was a drug abuser. Crack cocaine was their drug of choice. So, and he was one of the higher functioning people in his family, believe it or not. And after listening to him, I said, you know, there seems to be, your issue seems to be each time you get high and you go out into the public, you get into some kind of trouble. I said, yeah. And then especially my brother, I said, well, why don't you stay home when you get high? And that way you can stay out of trouble and it'll keep you out of legal troubles and other things like that. I said, that's a very good idea. I think I'm going to start doing that. And, you know, internally, I was like, how could he not understand that? But, you know, I had to understand as a clinician, everybody's at a different level. And so I think that's another thing that we have to do. So 3 things: giving a person a safe place to express themselves. Number 2, never saying that you understand. 3, trying to engage in inflection.
One of the things in running, facilitating groups and even individual dialogues and counseling, one of the things that I found that worked pretty good was bonding in a sense. Whereas I would say, well, I like the way you put that, or hey man, I like those shoes you put on today. Sure. Those types of things, and you find out. So what happens is, you know, you're bonding and you're gaining what Imam Shareef had alluded to, trust. The individual starts to trust you through the process of bonding with them.
Yeah. I think it's interesting because a lot of what I've heard so far is kind of relevant to an individual relationship with a patient, but I'm looking at the historical relationships that the institutions have with these communities. I recently was a caregiver for my father, who's 74 years old. And one of the things that bothered me was that the nursing staff and doctors called him by his first name, and he was 74 years old. They didn't give him the respect. I was immediately flagged. Dr. Hameed, El-Amin, can you please share with us what the historical context is and why the communities shy away from this trust institutionally?
I think the constructions, even in our sciences, they have cultural underpinnings. And of course, culture is socially and is socially constructed and influenced by social constructions. We don't have to think very deeply to think about what those are. Racism and sexism being 2 of the most prominent. And in that case, it creates that kind of mentality. So in that sense, science itself has been confined to thinking in terms of social influences without really spelling out what the connection is between those sciences and those social constructions and social influences. There's an idea that we've been discussing among ourselves with M.P.A.S and our work. I
just want to ask, there's someone in the background who has something that's going. If you're not on, your mic's not live, please mute yourself.
Yes, there's a concept by a scholar at the University of Massachusetts called cultural insanity. And there is such a thing as that. If we think of it even in terms of what racism does to individuals. And so we have to think in those terms. And really the amorphous kind of goal here that is still not clear, I don't think, in science, is that of, I think Imam Wahyuddeen already hinted at, that of elevating, and Dr. G, of elevating our conversations to the point of universals in which we can begin to understand science and what it demands of us in terms of how we treat people.
Thank you. I'm going to turn over to Dr. William Lawson and have him weigh in on this conversation.
Yeah, I want to note that I agree with what's been said, especially the interpersonal, but also I've been very much concerned with the larger issues in terms of the way in which the societal interacts. I was formerly a chairman and had an opportunity, came to, at that time, Howard University, plans of being able to bring in new technology, using that technology to improve mental health of the community, and was quickly learned that most of the people didn't want the treatment or didn't respond in the way that I would have predicted from those results. And I said, well, maybe there's something about the people in DC. Since then, I had the opportunity to try to develop a program in Austin, Texas, where I was an associate dean, and had the opportunity to actually create a mental health clinic, and saw the same kind of thing, and realized as I got to talk to some of the folks who developed various of the agents that we have, that unfortunately, they don't think in terms of what's good for the populations that we serve, but in terms of what's good for them, their own personal populations. And part of it has been educating them to recognize that both at a biological level, at a cultural level, and as a trust level, we have to change the way in which we introduce new products in terms of whether or not, how effective it can be and whether or not they're useful. I'm still very distressed that I have treatments that are effective in terms of mental health, substance abuse, but I can't get it to the patient because either the product in terms of the recommended doses are inappropriate, or the costs are extravagant, or there's psychosocial issues in society that prevents them. I'm struggling with we have an epidemic of drug overdoses occurring around the country, and we have treatments like agents such as Suboxone and others, but we can't get many physicians to use it, and we can't make it available. We have effective antipsychotic agents, but we can't get them to many of the patients because of cost and because many of the agencies that have these many of the people that have these don't know how to use them. So we have the science part of it is not some developing information, but developing information in which it is actually useful for the people that we need to serve. And that involves having them at the table in terms of making decisions about how you're going to develop these products and how you're going to make them available for the community. And it's not just the patients themselves, but also our audience has to be folks in terms of the legal community, folks in terms of the religious community, absolutely. And also folks in terms of the correctional system and others. All of them, I found, have a key role to play in terms of making decisions for what's needed. One of the unique features about American mental health is that we have a grossly fragmented system. And this fragmentation is not simply cost-benefit issues, but it also has to do with issues in terms of what makes sense for the largest, what makes sense superficially for the largest society. And perception of the individual is partitioned in terms of their general medical and their physical needs and others. So it's still just amazing to me when I go to mental health clinics, they don't have substance abuse treatment. When I go to primary care clinics, I have almost no idea what to do with behavioral health, despite multiple studies and efforts showing that integrated care is the most effective treatment. What we then find is the
Dr. Lawson, so I'm hearing all of these issues. What is the root cause of this disconnect, do you think?
Well, for me, I'm just dealing with the root cause in terms of racism historically. That's been important in terms of showing that that the people that we're serving are somehow an underclass, or somehow do not deserve the same kind of resources that we have for the larger society. In addition to the racism part, there's also a more philosophical role of the separation of the person from the science. That the science is something floating in outer space, and that what is the person, the myselfness, is something that is actually something very, very separate. So we need to bring these together in a way that makes sense and that we can appreciate. When it happens to us, we can appreciate it. When we get sick, we recognize. When I go to get treatment, I'm very much aware that I don't want to go to 5 different specialists to try to address my problems. I always try to set it up so I can go to 1 or 2 people in the system. And yet that's not what's available for most of the people in the country.
Let me ask Dr. Hale and Dr. G, how have you gotten past this systemic racism within your own institutions? It's hard for me to believe that it doesn't exist in those spaces because it exists everywhere else on the planet. So I want to figure out how have you gotten over those?
I'll take an approach first, and I would say, so my experience honestly was not learned in a college class, wasn't learned even in medical school. It was the community who taught me. I mean that my socio-historical lessons of Baltimore City came from the community. I mean, I didn't realize that the majority of Confederate soldier building names were intentionally placed in Western Baltimore, right? That was an intentional thing. I mean, it blows my mind, and they continue to have those names, right? The community taught me that. From Reverend King to the Imam to others, many people would, and that I was beginning to realize I got to listen. I got to, like, there's so much of that past. And I say this not to sound like I was sheltered in schooling. It just, no one discussed it. And it was rather disgusting that I, becoming a physician, that was the first time I was learning of it. With that said, I was somewhat, my Venn diagram can overlap a little bit because growing up in an immigrant community, we had many xenophobic attacks at us. The names, once I began to understand what, English was, I kind of picked up some ethnic stereotypes that were thrown in our way, but I don't know, the community always shielded me from that. Going out into the community, listening to this, that was important. And from my standpoint, not to oversimplify a complex strategy, but it really is still listening, taking that in, not ignoring it, making sure also the next generation of healthcare professionals are fully aware of that past, because the only way to write a new future is to be aware of the past. And that's where, taking Dr. Hale's approach and everyone else is here. When we meet with the community, we make it clear, we're not trying to, let's make that present, let's make that known. And let's write what medicine and healthcare systems should be like moving forward, right? That's the only, from my standpoint, a nice collaboration is the only way we move forward. It doesn't mean we solve it. It means suddenly we got good partners collaborating to kind of do something bigger that we individually couldn't do.
Dr. Hale?
Yes, I'd like to add on. So I came up here in 2011, and shortly before I did, there was the publication of a very important book called The Immortal Life of Henrietta Lacks. And so I see some nodding heads. And I use that because it helped me understand the community of Baltimore. It also helped me understand that this institution, this great institution, has made many, many serious mistakes. They have created problems, not solved them sometimes. And I think that that book sort of certainly opened my eyes. And so I didn't come up here with a sense of defending Hopkins. I mean, Hopkins has its own flaws. And so I've never felt that I had to be defensive about what I'm doing. And I've just always wanted to focus more on, like Dr. G says, let the community educate me. And it does a good job as long as you show up regularly and you let them know that you are listening.
When you say a lot of the racial disparities in health come into your workplace, does it ever resonate? Does it, like, how can I address this in a way that not just deals with that individual patient who's coming through the door, but systemically deals with why they're being funneled into this space in the first place?
Yeah, and I'll pick up, and I think Dr. G will have something too. Particularly, he works in an office along with Sharita Golden, and so I think but we have some wonderful people. Dr. Lisa Cooper, who now heads up our Urban Health Institute, who has really built a career and has become internationally known for identifying and addressing many of those structural elements. And so it's not just one-on-one with a patient. It is indeed addressing housing, addressing discrimination, addressing food insecurity, these things, recognizing that this culture here is responsible. The broad culture here is responsible for many of the ills that we treat in the hospital. And we can't just wait till they come to the hospital. We've got to be proactive, and we have to be, again, humble about this. So, and Dr. G's very involved in these programs.
Yeah, no, it's incredibly spot on, and the one frustration that a hospital, the way it's been made and created, it's so reactive. And I'm a critical care doctor. Right? I go out and speak about, in hospital outcomes right now where we're at in the 21st century, get leveled off, right? We do good to kind of implement interventions, but disproportionately still many populations suffer from those diseases by the time they get here. And my frustration with with modern medicine is we just turn a blind eye to that. It's like, if you come into my medical intensive care unit, come in one day, right? I would guarantee you, I'll be bold, 100% of those patients in there, all could have been prevented, right? Access to medications that led into their DKA, substance abuse that led into their alcoholism or alcohol withdrawal. I can guarantee you, and that's what you see in an ICU. You see health disparities at their worst. And if you peel back the systemic issues that happen in the community, I mean, yeah, a healthcare system has done, some way, shape, or form has done a really nice job to contribute and feel not responsible. And that's frustrating. And the only, the question of how do you overcome it? You overcome it by people discussing and identifying those factors, beginning to shift the culture of responsibility, meaning take that on. We have to. We can't just turn a blind eye, even though we're contributing to it. And where we can't contribute to it, begin to advocate for it. Finding, how can a hospital overcome the transportation that was intentionally created in Baltimore City to keep access limited? If you've ever been to Armistead, that's far east side, that's an urban island. One bus every 90 minutes, that was intentionally created, right? To overcome it, yeah, maybe a hospital may not feel responsible for it, but it's got to start becoming a partner to collaborate and overcome those. So right now, in my opinion, I mean, the status quo can no longer be accepted. And that's not me identifying it as an intensivist, it's the community pleading for it. And so that's where I think community engagement continues to play a role. We want to knock down these systemic issues. It can only happen if we all collaborate and get together. And those who are closest to the problems are usually furthest from their resources. So we got to be conscious of that and get people what they need in some way, shape, or form, either access to care or advocate for their care. But I promise you, we're doing it. We're doing our best to move forward. But it is, the systemic racism that's there. It is so complex. The web there. Peel one thing down and you realize there's more to open. Just got to continue and be persistent. That's all we can do, but we'll do it.
Ask the imams, historically, there's always been oppressed peoples in society. So what types of lessons have we learned in history that you can apply today in connecting the systemic racism within all of the institutions that community deals with, but particularly in health? Imam El-Amin.
You're on mute, brother Imam. You're on mute.
Can you hear me now?
I can. We can hear you.
Okay.
Yes, we can hear you now.
All right. I think from a historical perspective, we look at one of the things that I didn't hear is prevention. And I came through a community when I first became Muslim, where prevention was the order of the day, that it was physical, mental, and spiritual. There was a saying, you are what you eat from your head to your feet. And that what was implemented in that was that being healthy was normal. And we were coming out of neighborhoods and communities that where there, people, substance abuse, alcoholism, the whole shebang here in Baltimore City. So for me, prevention was the order of the day, and still to this day, it should be the order of the day. And I still don't hear it, because in the Western mind, it's always reactionary rather than prevention. The Western thinking is still permeates reactionary. Now, that's driven in a sense by capitalism also. So we have to be cognizant of that. It's driven by capitalism, because on the back end, it's always we can make more money on the back end, because if an individual comes in and he's practicing or she is practicing prevention, then you don't have you can't make any money. But on the back end, when the individuals that come in to see Dr. G, I mean, if we caught them on the front end, then there would be 50%. If we cut 50% of them from not coming back to see Dr. G, then we would be very successful. So it's all about prevention. I came through a community where the Honorable Elijah Muhammad promoted healthcare, and he wasn't a doctor. He only had a third-grade education, and that was from Deep Step, Georgia. So you can imagine in 1919 what that type of education was. But he had the wherewithal to understand what it meant as it related to prevention and healthcare. And so he even published a book, How to Eat to Live. And so a lot of people who later on, healthcare practitioners, use that as a springboard to their successes.
Okay, Dr. G.
I want to build off of what you said, Imam, because there's going to be many barriers that we'll identify that are keeping us from doing good, right? That's the part that, as an adult, I mean, I know we're all adults, but when you shed the innocence of childhood, thinking everything's good, and then suddenly just doing good, many barriers get thrown up. Right. I say this because even this community engagement efforts, meeting Dr. Hale, if it wasn't for this person, I wouldn't be doing it, because all of academia told me you don't make a career out of this. And then suddenly a few people were like, no, you can, and do it. But what I'm going to get to, Imam, what you said about the capitalistic part, yeah, we got to recognize that is a big barrier for many of us, or for institutions, to knock down the systemic issues that were created. One example another aha moment, this came from going into a boardroom, population health. I'm a critical care doctor. #1 cause of death in my ICUs is sepsis, which is organ damage brought on by the immune system in response to an infection. In layman's terms, given severe COVID is very similar to pathophysiology of that. Now, what I did is I showed the poorest areas of Baltimore have the highest rates of sepsis-related mortality. They die a lot more. And then I took another map and said, but incidence of infections is the same, whether you're poor or rich, same incidence of infections, meaning why is the poorest sections, why is their physiology worse off than the more affluent? And I say this because I got a lot of like, oh, that's upsetting and frustrating. No resources, nothing. Deaths didn't move the needle. I went back 2 years later and I said, well, sepsis leads to a lot of readmissions to the hospital. Well, readmissions in a Baltimore hospital, in the Maryland hospital, is a lot of money lost. Guess how much resources then people started to discuss with me. They're like, oh, what can we do? What do you need? It was it was a capitalistic standpoint, and I recognize that, and I grit my teeth around it. But that's what moved. And so I say this because we got to be aware of what the barriers are. We can't turn an ignorant eye towards it. At times, we can actually bend it to do good, and I get that. But there's going to be a lot of barriers towards doing good. And the part that we can't lose sight in is our energy to tackle that. And this is actually one of the reasons I love what we're discussing now, because it's always good to know there's other people who believe in the same missions, and collaboratively coming together, we'll do this. We'll overcome the barriers that exist, but we got to be conscious of them first in order to break those walls down.
Thank you, Dr. G. I want to ask Imam Wahyuddeen Shareef to also comment on that from a faith perspective.
Well, it's interesting that with the assistance of Samuel Shareef, recommending that we read both the books by our doctors, Dr. Hale and Dr. G, I started reading the books. And it's interesting that both of them pointed out the significance for change, right? And how the disposition that is associated with care has to be changed. And when I read about healthcare, particularly mental health care, from an Islamic historical perspective, I read that it was called Ilm-un-Nas. The whole concept of mental health was called Ilm-un-Nas, which means the science of the soul.
Oh.
Which means the science of the soul. So they weren't just looking at the physical aspects of what perhaps was affecting the individual, but they were affecting the mental as well as the spiritual component that was ultimately affecting the individual. Because again, going back to something that Dr. Lawson said, the fragmentation that is associated with how treatment is delivered also is associated with how we fragment the human being. We cause the human being to look at oneself not as a holistic person, or we don't look at him as a whole person. We only look at certain elements of that person. Well, Islam is, the principle in Islam is called Tawheed. What is Tawheed? Tawheed is oneness. It is a unity in it, looking at the wholeness of the individual and being able to treat and being able to grow and being able to nurture that human being in a very holistic way. So the approach that I believe that this subject has to take on is a change in how we perceive the individuals that we're trying to help. Al-Islam is called an integralistic faith. It's called an integral, which means what? It's a trust or a belief that has a moral code to it, which brings us to the other component of this intersectionality that we're talking about, right? The ethics that are associated with how people are dealt with. And if we understand how we're going to really help people, then there has to be a moral code that those individuals who are treating people live by. And if that moral code is somehow or another distorted, or that moral code somehow or another is just disregarded, then the treatment that is going to be given to those individuals is not going to be the kind of treatment that is going to bring about a whole person that we're trying to rebuild. And I think that's one of the components that we have to look at. When I read about ethics, it was interesting. I'm just going to read this. He said, ethics is a term refers to the field of study or branch of inquiry that has morality as its subject matter, identified as moral philosophy, a systematic study of what human beings ought to do, reflecting on the best way to live. It introduces moral codes of behavior that help teach and guide human beings to reason, understand, and follow the ways of doing what is right. That is what we have to begin to incorporate into the treatment, not only of the patient, but also the treatment of the individuals who administer the care. You're on mute, Sister Latifa.
On mute.
Sorry, when I listen to what you said, I hear the underpinnings of love. And I'm interested in others' perspectives as to how love manifests in the work that you do, not only day to day, but over the years as you develop experiences. How do you approach these issues? And give me examples of that work. I'm going to ask Dr. Hale.
Okay. No, thank you. Well, let me start by saying I don't know where my activism developed, but it's always been there. And I have actually felt out of place often in the psychology field. I think so many psychologists are content to just try to heal the wounds of that individual. It always seemed to me the responsibility was to learn from what I was hearing in my therapy sessions and find ways to address that in the community at the same time, to try to prevent those conditions, whether that's hearing a woman who's been abused and trying to find ways to, address that in the community. So prevention it hasn't ever been for me either or, it's been both, because one informs the other. For me, I come out of a Christian tradition all the way from childhood, from what we called the cradle roll when I was an infant. So faith communities have been a part of my life, and I've been taught love. And somewhere along the way, probably more as I got into my teens and started learning about broader things, to me, love had to be translated into justice. And that's what became important to me, that it wasn't enough to just feel good, and that to recognize the inequalities, the inequity, the disparities, that's just not right. But I can't just go around, I shouldn't just limit myself to saying, I love you and what can I do for you? I have to address it at a broader level. And that's just sort of been a part of my life and career.
If I may, in Islam, the first social principle in Islam, it's on the, I think, the first social principle in Islam is justice. And as Muslims, we believe that justice will lead us to love. If we're just with everyone, the hardest thing is to be just. So justice leads us to love. The other thing I wanted to say, El-Amin, you said, Imam Shareef, El-Amin, the study. Well, in early psychology, the psychologists would say that the psychology is the study of the soul. Some kind of way now it has gotten away from the study of the soul, and now it's just a study of the mind, I assume. So I think what Imam Shareef alluded to, we look at we have to look at, we are obligated as Muslims to look at the individual in its totality. The other day, I was remarking to another friend of mine about my back. I've been going through back treatments. And I said, man, it's really not my back, and it's my hip. And he said, hey, come on, man, everything is connected. If you understand what I'm saying, everything is connected. So we see the world, we see ourselves, we look into the heavens, we see everything is connected, and we look into ourselves and we see that everything is connected.
Dr. Hameed?
Yes, there's a lot to be said here, but we see the disconnect in psychology in the sense of what Imam Wahyuddeen and Imam Earl just said, in the sense that we not only disconnect the idea of the mind from the soul, which is, of course, a disconnect between those things that are spiritual and that we must be spiritually informed in order to appreciate. But it also means the self. And that self is something that we're individually responsible for. So without that spiritual connection and that ethical approach to justice, that is not spiritual itself, it's rational. Then, and Dr. Hale spoke very, very candidly of that in his own experience. And I think all of us can. I feel the same way he does. I grew up with this in my soul, and that isn't something we always appreciate. The other disconnect that's implicit in what was said is a disconnect between emotionality and our rationality. Those two things have been separated also. The spirit and the intellect have been separated so that we have this objective view of science, which when it excludes those things that are spiritual and emotional, can't remain objective in the sense of respecting the whole of what it means to be a human being. So we think of some things, some social constructions, and some people and some aspects of our sciences and our logic as being objective when they really aren't, because they don't take into consideration those things that are holistic in their sensitivities, in the way that we apply them. And so that becomes that the source of that cultural insanity that we see in the culture wars every day on our television. And we can translate those things into clear clinical terms: anomie and alienation, those things that we see both in the individual, but we can also see metaphorically in the society itself, which induces those problems and leads to this back and forth, these insecurities, these disconnections that we all recognize.
Can I make a quick comment, Latifa? It's interesting, the subject that we're talking about. When I was reading, one scholar talked about the Islamic society and how the Muslim society is designed to grow, right? And designed to grow. When he talks about this, he's not just talking about the fact of just Muslims. He's saying that the Muslims are supposed to be an example or a model for the rest of the society, right? And so he said that in order to grow the Muslim society so that it serves as a model, there are 3 stages of the development that it must take on. And he said it's knowledge, appreciation, and love. And then he went on to say that you really have to start with some knowledge, and then you gain some appreciation as a result of the knowledge. And you can't get to love unless you have some appreciation for what it is that you have a relationship with. And so the relationships that we're talking about in terms of healthcare have to, I believe, be based in those 3 principles: knowledge, appreciation, and love. And when we can fulfill those standards that are associated with how we relate to people, then I think we'll be doing justice to the individuals, because we're bringing information, we're bringing illumination and enlightenment to the subject matter that ultimately is going to cause that individual's life to ascend, to grow from where it is into the level where I think God wants every human being's life to be. And that is a life that is peaceful, secure, and productive.
I think it's interesting that you talk about it from that perspective of knowledge, appreciation, and love, because if you look historically at Muslim interfaith relationships as they pertain to health, you look at the Moors of Spain and how they work collectively with the Jewish community and other communities to really have a renaissance of health, where you could look at the urine and know 20 diseases, or you look at what happened in Timbuktu, which was a melting pot in Mali of knowledge, also connected with faith, and having that be something that people did author throughout the society because they had such a genuineness to want to learn. You can see how history has shown examples of how this has worked when people are genuinely interested in the outcome of the other. And I think that's also a part of this is when you don't love the other like you love yourself, if you don't have an understanding of the soul, Nafs and Wahyuddeen, they were all one soul, then you're thinking of that other person as kind of a luxury that you could help. But in actuality, by helping that person, you are also helping to mend your own pathway forward as an individual and as a society. I'd like to ask Dr. To weigh in on that as well.
Okay, yeah, so one of the attributes of Allah subhanahu wa ta'ala is al-wadud, the most loving. So when we think about this concept, you know, he's kind of manifested that aspect of himself in our natural fitra, and what we understand as fitra is our natural way. So when we go against that, you know, due to the influence of shaitan or the devil in Christianity, and each religion has their own concept of this. You see these kind of ways in which people act out. So, you know, for me, coming from a place of love, I try to remember that as a Muslim, that I'm trying to do God's work in the healthcare that I do. And it's very interesting to note, since we did talk about the racial aspect in mental health. When we see young Black men enact in violence, they're oftentimes considered just evil or naughty by nature, if you will. But when young white men may engage in the same activity, the first thing that we go to is like, well, do they have any mental health issues? But both of these groups are going against their natural fitra. So our natural way is not to be murderers, or our natural way is to be kind and compassionate to each other. So we use this concept, Dr. Hale. So in Islam, we've got Ar-Rahman, Ar-Rahim, the most merciful, the most compassionate. These are what we understand to be attributes of the Creator, or Allah. And they're manifested in us, and we can manifest them when we provide the type of healthcare that we do to our patients and clients, and you know, do so in a structure that's kind of consistent with a holistic nature, as Dr. Lawson was alluding to.
Appreciate you bringing it round to that. Imam El-Amin, as he talks about this idea of mercy, because, you know, I oftentimes look at this word justice, and if you look at it, in order to be just, somebody actually has to kind of lose for you to get there, because you really have to compensate for any damages from previous, right? In order for it to be all of us moving forward, you're really anchored in a concept of mercy, because you have to look at what's just. You may have to forgo that which is just. They would say, you know, you have the opportunity for an eye, but if you do one better and forgive that, it's better for you. So the mercy is the overwhelming thing that when I think of Islam, kind of is the front runner. What are your ideas around mercy and health?
I think as a practitioner, that should be, as you said, that should be the narrative which drives you. Being able to benefit someone and help them in a capacity which they can't help themselves. It's the same concept of when we say Bismillah ar-Rahman ar-Rahim, with God's name, the merciful benefactor, the merciful redeemer, that God is the benefactor, but man can also be a benefactor. The human being can also be a benefactor. And the human being is, all the human being is doing is taking the attributes and practically applying those attributes in their lifestyle, day in and day out, regardless of whatever their profession is, whatever their role as a mother, father, husband, neighbor. That should be the preeminent what drives us. Mercy is what drives us.
I think it's interesting to note, as Imam El-Amin is pointing out, that there's a verse in the Quran that says that Allah says that He expands and he encompasses his creation in ilm and rahmah, in science and mercy, the two elements that are associated with how his creation expands and how he encompasses his creation. When we understand those concepts, then we understand that the science should give birth to mercy. The science should bring mercy. The more we advance in terms of intellectual capacity, the more we advance in understanding creation, the more mercy we should be able to administer to the creation that we're part of. We shouldn't be destroying the creation as a result of science. We should be improving the creation as a result of science. And so when we start talking about the mental health that is going to be administered to people, then yes, mercy has to definitely be a major component of how that treatment is administered. At the same time, the science and the education and the knowledge has to be very all-encompassing. It just can't be narrow-minded to the physical or the mental. It has to take into strong consideration the emotional and the spiritual components that also need to be nurtured in that individual.
I would also say, to dovetail off of what you said, Imam, and notice I didn't say piggyback. But that the Quran also says that everything in the creation has a mercy and a knowledge for you. That everything in the creation has a mercy and a knowledge for you.
I oftentimes think about that you can apply the same science, the same medicine to any individual and have a totally different outcome. And the consistency seems to be whatever the mercy is from Allah subhanahu wa ta'ala. That's the most consistent part of it.
Absolutely.
Dr. G, I know you just rejoined us again, and we were talking about this idea of mercy versus justice, or maybe in addition to justice.
Yeah, no, and sorry, I stepped away. The 4-year-old still acting up. So, I don't know what more to add to the great insight that's being provided to some extent. What I'll keep from my standpoint, one thing I'll continue emphasizing, being a physician is an interesting scientific field. Being a healthcare professional, you learn so much science, and then what really leaves you at the end of the day is the patient encounter. Discussing with the patient about putting her husband finally on hospice after years of battling a disease, or having a breakthrough moment with a young patient who finally was able to conceive. The humanity is always, to me, the most important thing that comes away from the science. And to me, there's the same concept with community engagement, right? To balance the mercy and justice, those are things that are identified by the community you work with, right? It would be ignorant of me to kind of put some level of a priority that they should aim for. No, you listen to the community, and the only way to gain that is through their lens. And you build on that, and you see where science can help, and you see where you can bend the arc of pop health strategies and so forth. But from as a physician, mercy, justice, those conversations individually happen in a clinical arena, yes, but on a grander scale, they happen by being bedside in the community. Your community kind of gives you that perspective and that lens. And I say this because, especially when you work with diverse communities, you don't know what mercy and justice means to them until you can't walk in their shoes. As our colleague said, it's not that you understand, but you can discuss walking next to their shoes and discuss walking with them in order to kind of get a sense of what those factors mean to them.
I appreciate everything everyone has said, and I'm going to pass the ball to the audience who have questions in the chat box, and let us take advantage of the last few minutes with that. I did note that Imam El-Amin said piggyback, and the concept of the pig is gluttony, and the opposite of mercy is gluttony, because you're only thinking about yourself. You're not thinking about the other person. So these concepts are not just based on, culture in itself they have many meanings to go out and how you actually actualize your interactions with others. So we're going to go to chat.
And the dove is a sign of peace.
You said, say it again?
And the dove is a sign of peace. He said he was dovetailing.
Oh, he was dovetailing.
Dove is a sign of peaceful coexistence, right?
Okay, I missed the dove. Okay. I'm going to read this question in the chat, and if it's whoever feels most compelled. How do we help out communities to accept of each other's shortcomings and not socially outcast or hide the mental health within the families, or to be part of stigmatizing the person with such issues? There is a stigma in general, but a lot in our Muslim community in the United States.
Yeah, I'd like to answer that to the best of my ability. I worked at an outpatient clinic many years ago, and walking in one of the into the lobby area on my first day, it's an elderly Black lady that looked at me and said, "You work here, sir?" I had my white lab coat on and my stethoscope. She said, "They finally got a Black doctor here." So it was kind of telling, because a lot of the folks that were there, probably half the patient population was what we call African American, and maybe 40% was Hispanic, and maybe less than 10% were white. Well, when I started doing the primary care in conjunction with some of the mental health care, I saw a great deal of differences with how each group deals with mental health and the stigma thereof. So as Black men, a lot of times, and Imams, see if you agree with me on this, we're supposed to be tough. So, brother, man, look, come on, don't be crying about your problems, just suck it up, especially if you're from the hood. Now, I'm not from the hood, but I grew up in DC, so my parents protected me from that. But you just didn't talk about your problems. You didn't cry in front of people. You didn't whine. It was considered almost effeminate in some ways. Now, the white patients I had, they would actually get together and talk about their different therapists. Oh, this therapist is much better than that one, and this one's got me on Paxil, and this one's got me on Wellbutrin or whatever. So I would say in our communities, the Black community, and the African American religious community in particular, sometimes we are part of the problem in a way. I had an Imam tell me that, well, these people that aren't dealing with their mental health issues, they're possessed by jinn, or, they don't have enough Iman, they don't have enough faith. And that's why they have these mental health issues. And I said, well, listen, some people have got real genetic health issues. And Dr. Lawson, I know, I'm a Howard alum. He's done a lot of research on neuroanatomy and neurotransmitters and so forth. So we know that organically, people have got problems with the brain, very, very real organic problems for which they may need medication. It's not helpful if you go to your Imam, or you're part of somebody, you may be identified as somebody who has a mental health issue, and you're in your Muslim community, and people are looking at you, watch that brother, man, he's got issues. I'm telling you, man, watch him out, watch out for him. And, ironically, these are some of the same things that were said about our beloved Prophet Muhammad, peace and blessings be upon him, that he was majnoon, crazy, right? So we hear this a lot. So overcoming that stigma, it has to be education at the basis of it. Yes. Why is a person a certain way? Why are they acting out? I took a course many, many years ago, maybe 3 decades ago, called adult psychopathology. And back then it was the DSM-3, Diagnostic Systems Manual 3. So we learned about a long
time ago.
Yeah, man. Yeah. Well, I'm pushing the big 6-0, man. So I'm a little older than I look. So we learned about.
Speaking of time, we have to wrap up.
Oh yeah, I'm sorry. So we just have to do a better job within our religious communities of educating ourselves, and then educating the public about what constitutes mental health. I believe that mental health education is one of the key components of overcoming the stigma.
I'd like to thank our scholar cohort, the strategic planners of the Muslim Life Planning Network. We're excited to be here for the 14th Annual Muslim Mental Health Conference at Yale University, Unmasking Intersectionality, How Ethics, Trust, and Culture Influence Society, Mental Health, Engage Hearts and Minds. Thank you.
Thank you.
Thank you.
Thank you.
Can we just, I'd like to just have it for the record. I want to go on the record and give special credit and special thanks really quick. I just want to also comment, this was a dynamic session and I appreciate the time spent in the preparation as well as the presentation. We'd like to thank the Muslim Mental Health Consortium, part of hosting this conference, Institute for Muslim Mental Health, the Michigan State University Department of Psychiatry. I'd like to also thank Johns Hopkins Bayview Medical Center. I'd like to thank the Medicine for the Greater Good. I'd like to thank Howard University Hospital, Emotive Architecture, Washington, D.C., Red Dove Architecture, Washington, D.C., all of our staff and team members at the Muslim Life Planning Network, Muslim Life Planning Institute. I'd like to also thank our scholar cohort, our community partners. Thank you so much. Last note, you all will be receiving an email. We'd like to do a debrief on Monday at 3 p.m. Hopefully that works for you. I'll send you an email and let me know if you can make it. Thank you so much. Thank you. Assalamu alaikum.
Thank you all. Congratulations. Latifa,
Thank
great
you.
job.
Good job, Latifa. Yeah, you did a good job.
Great job, Latifa.
Assalamu alaikum.
Alhamdulillah.
Thank you, so
Thank you,
much.
Dr. Hale.
Thanks.
Thank you, Dr. G.
Awesome. Thank you all.
Thank you.